Hi, and welcome to Understanding and Working with the IDD Population Part 2. This will be presented by myself, Jamie Brewer, and the rest of the IDD Clinical Management team. Please ensure you have watched Part 1 prior. The objectives is to review trauma-informed care implications to people with IDD, identify how treatment modalities may be adapted, and considerations for people with IDD, and understand people with IDD and their unique needs, including sexuality. Trauma-informed care. Prevalence of trauma. Children with intellectual disabilities may be 3 to 6 times more likely to suffer abuse than neurotypical children. Women with mild intellectual disabilities are about 5 times more likely to suffer sexual abuse than women without disabilities. Not only are individuals with developmental disabilities more likely to be exposed to trauma, but exposure to trauma makes developmental delays more likely. Severe neglect can result in reduced brain size, density of neurons, and head circumference. Trauma-informed care implications. Due to high incidence of abuse in individuals with intellectual disabilities, it is important that mental health and DD service providers, number 1, understand the concept of trauma-informed care, and number 2, create service environments that are sensitive to the needs of clients who have experienced trauma in their lives. Trauma-informed care is an approach to engaging individuals with histories of trauma that recognizes the prevalence of trauma symptoms and acknowledges the role that trauma has played in their lives. Using trauma-informed approach. Mental health professionals should also be aware of a highly trauma-informed initiative that has been underway within the DD sector for many years called the Positive Culture Initiative to bring about conversations about building collaboration within the DD systems to create healthy relationships within organizations with the goal of improving the quality of life for people with developmental disabilities. The central focus of gentle teaching is to express unconditional love for initial teaching purposes to teach others to feel safe, loved, loving, and engaged. Please reference a gentle teaching primer.
How do you bring about positive culture initiative?
Positive culture initiative and community involvement. Community inclusion involves the idea that all people, regardless of their abilities or disabilities, should be able to fully engage in various community activities. Community inclusion provides those with developmental disabilities the opportunity to live and exist as a member of society while being recognized and valued for their uniqueness and abilities. The ultimate goal is for those with intellectual and developmental disabilities to be able to participate, if able, in employment, housing, recreational activities, leisure activities, education, peer support, friendship skills, problem-solving skills, increased self-image, respect for others, peer models, and a greater understanding of accepting differences in individuals with developmental disabilities are all evident when community inclusion is implemented.
Are you able to give a few examples of gentle teaching primer?
Sure. So a few examples would be, for example, caregivers can model asking for a hug by saying, I can sure use a hug, or could you give me a hug? The use of loving touch gradually takes on a new meaning of gentleness, companionship, and community. The caregiver's hands can be concrete expressions of generating a feeling of being safe and loved. Trauma and IDD. IDD clients are taught to be compliant, making them easy targets. They often have limited communication skills to facilitate reporting of abuse. Clinicians who believe talk therapy will not benefit clients with IDD will be resistant to provide support, so clients will be left with only behavior modification interventions by staff to the problems they have developed in response to trauma. Resiliency supports such as peer relationships, participation in extracurricular activities, and family supports are often already minimal with clients with IDD. Here is a trauma-informed approach handout. So using trauma-informed approach. So you have trauma-informed and non-trauma informed. What happened to you is trauma-informed. Non-trauma-informed would be what is wrong with you. Trauma-informed, recognition of high prevalence of trauma. Non-trauma-informed, lack of education on trauma prevalence and concept of universal precautions. Trauma-informed, recognition of primary and co-occurring diagnosis. Non-trauma informed would be overdiagnosis of schizophrenia and bipolar, conduct disorder, and singular addictions. Techniques for effective support. Attitude is everything. Observe, listen with eyes, not just ears, gather information, review all documentation, ISP, PCP, evaluations, assessments, encourage, respond to challenging behaviors with empathy, neutral face expressions, and controlled tone of voice, plan for success, routine, know, respect, and implement, consistency, choice, and allow them to have control, communication, and decrease boredom. Best practice recommendation, attitude is everything. If we are not positive and excited for the session, the client likely is not either. Techniques for effective support continued. Resolve conflict in a positive manner. Let's review the handout steps to conflict resolution. Number 1, set the stage. Gather perspectives. Find common interest. Create options. Evaluate options. And create an agreement. Again, best practice recommendations for conflict resolution. Refer to the handout Resolve Conflict in a Positive Manner. Conflict resolution is of critical importance. Conflict between peers can lead to acts of bullying and violence. These six steps are an excellent introduction to conflict resolution. Once again, this framework can be and should be taught. Adapting VPBS services. Balancing role of support and confidentiality. We often need collateral information from care providers as clients with IDD are poor historians, but at the same time keep confidentiality. Care providers often may help when the client has very limited language skills as they are more familiar with their speech patterns. The care providers are also valuable in helping ensure that the treatment recommendations are followed and homework is completed. Useful guidelines for speaking, interviewing with individuals with IDD. Keep in mind when speaking with individuals with intellectual disabilities, confidentiality still applies regardless of the IDD diagnosis. Still need permission for collaboration and working with care providers. You can refer to the useful guidelines for speaking, interviewing individuals with ID. When adapting BPVS services, keep in mind the client's level of intellectual functioning, the presenting symptoms that lead to the referral, how the symptoms compare to the client's previous level of functioning, how mental health symptoms interact with behavior that is typical for the client's IDD or DD, what types of stressors the client is facing, what skills the client has used to manage similar stressors in the past, and your own bias about IDD and their ability to engage in the treatment process. Adapting VPBS services. Typically, clients with IDD are not self-referred. Most come into treatment referred by someone else concerned about their maladaptive behavior, a parent, caregiver, etc. They may not have any idea about what therapy, TBS, psych is. They may not see the problem as an area of concern for them, or they may see the referral as a punishment or consequence for their behavior. They may not have any input into the choice of the therapist or who will even be present with them during the appointment. Adapting VPBS services. The majority of clients with IDD have many professionals involved in their care. Case managers, habilitation providers, job coaches, behavior support specialists, and a variety of direct support professionals. Clients with IDD may have no understanding of how the therapist's TBS role is inherently different than all the other members on their team. They frequently experience the free sharing of personal information between multidisciplinary team members and may have concerns that the information disclosed in therapy TBS sessions will be treated in the same manner. Initial interview/session. Give a brief explanation to the client regarding what the meeting will be about. Some simple examples you can give that must be tailored to the client's level of comprehension include, this meeting is a chance for us to talk about things that bother you. You can also talk about good things and the things you like to do. Is that okay with you? Ask the client to repeat back what they heard you say by introducing a checking back as a regular part of the process session. By praising of their efforts to feedback, be praising of their efforts to feedback your communication. Check out your understanding of what was said to you, asking if you got it right. Dr. Genitelli often uses a phrase, can you fix it for me? If she has not quite gotten what they are communicating to her. Most clients with IDD experience receptive and expressive language limitations and may not be able to self-report their symptoms. Establish that the cognitive deficit is a legitimate and neutral topic of discussion from the beginning, so that issues regarding communication can be addressed openly. This is crucial to establishing the therapeutic alliance. Clients with ID may also struggle with expression of emotions and feelings. This can be extremely debilitating, and they can feel overwhelmed and frightened by intense emotional response that they do not understand. The ability to identify and label feelings provides a sense of control and comfort that can increase a client's capacity to appropriately manage their feelings. We may need to interrupt behavior for a client we may need to interpret behavior for a client with IDD by identifying and labeling the emotions that are tied to the events discussed in the session. For example, you look sad when you talk about how sick your grandmother is. Other activities that can facilitate the labeling of feelings and emotions include use of pictorial representations of faces to facilitate identification of emotions, use of journaling if they have the capacity, use of picture journaling as substitutes for writing or drawing pictures or putting pictures into a journal, expressions through music. Adapting specific modalities and interventions. Modalities that can be adapted. DBT therapy, developed by Marsha Linehan in 1993 to address the needs of clients diagnosed with borderline personality disorder who were chronically suicidal and not benefiting from traditional treatment. The goal of DBT is to validate the client's behaviors and reactions are understandable without agreeing that they are the best or the only approach to solve the problem. DBT focuses on helping them learn to regulate their emotions and improve their ability to cope with stress in their interpersonal relationships. DBT for special populations. The main tenets for DBT remain unchanged. However, the presentation and language were adjusted to a level that the persons with IDD or DD can more easily comprehend. Pared down concepts to allow for better comprehension and ability to apply the material. As TBS, we are not trained to provide DBT therapy. However, we can utilize techniques such as coping skills, including mindfulness, self-soothing, grounding, and meditation.
Who is Marsha Linehan?
Sure. So Marsha Linehan is an established treatment development researcher with 30 plus years of experience conducting behavioral treatment research with individuals at high risk for suicide and leading a research clinic that has already been successful at developing effective treatments for suicidal behaviors. In addition, she has developed and researched assessment measures related to suicidal behavior, including the Reasons for Living questionnaire and the Suicide Attempt Self-Injury interview, as well as methods for DBT and other evidence-based therapies required to successfully treat chronically suicidal individuals. Modalities that can be adapted. Cognitive behavior therapy, CBT, is an effective treatment for depression, anxiety, and other psychological disorders. Adapted CPT with clients who have learning disabilities through the use of ABC or functional behaviors assessments. ABC stands for antecedent, behavior, and consequence.
Can you tell me what is an antecedent, behavior, and consequence?
Sure. So an antecedent is any situation, action, or event that precedes a behavior. A behavior is an observable and measurable act, and a consequence is any response, action, or event that allows or that follows a behavior. I'm sorry. Okay, this is a visual representation of ABC, of behavior, and you will see the functional assessment of problem behavior, behavior basics, so setting events, establishing operations, what sets up the behavior. You'll see antecedent, behavior, and then consequence, what is the payoff for the behavior. Again, this is a visual representation of the ABC of behavior, and categories were described above. Example, behavior is taking the test. Antecedent, studying or relaxing and not studying. Then the consequence would be fail or pass. Common for staff to say, he just started being aggressive for no reason. Always ask what led up to this event. What was said and occurred before? Functional behavior assessment. A pattern of behavior that repeats. Understand why the behavior occurs. What are the antecedents, precursors? What sets off the behavior? Are there any setting events, things that set the person up to do the behavior? What are the consequences, outcomes? What does the person get as a result? Is the behavior an attempt to communicate, a way to avoid or obtain something, the result of a medical condition or factor? Considerations. The slide introduces FBA, Functional Behavior Assessment, which is a way to understand the function of the behavior. The goal is to figure out what purpose a behavior serves for the individual. In other words, what makes it rewarding for them. The big difference between understanding function of behavior and traditional interpretations of behavior is from what perspective the behavior is viewed. Direct support professionals and clinicians need to understand behavior through the eyes of the person who engages in it, rather than talking about the problems it causes for other people. Most of the time, people talk about the behavior as an inappropriate or inconvenient. For the person, it meets a need that he or she does not get in other ways. This perspective is helpful through the remainder of the section. The main points to learn here. Number one, direct support professionals and clinicians need to focus on observable behavior, something they can see the person doing. Number two, there are basic elements that need to be understood and investigated in order to understand behavior. These include antecedents and consequences, which are discussed further in this section. Number three, behavior can meet the needs of a person and can make sense from the person's perspective. Direct support professionals and clinicians need to be able to identify what the need the person is attempting to meet and if the behavior is most appropriate, effective way the person can meet the need. Other modalities that can be adapted. Groups, coping skills reinforce working with others and break down isolation, mindfulness, stop technique, relaxation, progressive muscle relaxation. You can also refer to the handouts, the stop handout and the muscle relaxation handout that will be given in your TBS training workbook.
Jamie, can I just interject here for a moment?
Mhm.
So with the CPST groups, some of those groups are going to be, for example, hygiene. A lot of times we see individuals who really struggle with hygiene, and that can sometimes be a difficult conversation to have one-on-one, or if the staff at home have been working on it, or parents have been working on it. Sometimes having a group setting where others can provide maybe some positive peer pressure or can give some ideas of how they deal with some of those struggles can be very beneficial to the individuals we serve. Also, some groups that are helpful are boundaries. We have a lot of individuals that want to give hugs, that want to touch, that want to, they have that need to connect, and others have that need to not be touched. So talking about boundaries and how that affects everybody that's at the group setting and how you can reinforce your own personal boundaries without being mean. We have individuals that are afraid to be considered mean. So boundaries are another great idea for a group. And then social skills, how do you talk to people? We have a lot of individuals that have some anxiety based on how they've been treated in the past, whether it's in school or in the public setting. So helping individuals reinforce positive social skills to give them some confidence so that when they're not only in our day programs or at home, when they're out in the community, they can have positive experiences. The stop technique is just trying to get our individuals to stop, pause, walk away, look away, disengage somehow so that they can take a breath, give their brain a chance to catch up to the rest of their body. We want them to stop and observe what's going on around them, be curious about what they're thinking, what they're feeling, where do they feel the stress in their body so they can try to relax that. Be curious again, what's going on? Why am I feeling this way? How can I handle this? And then proceed with what feels like the next wise step. So slowing down the whole process so their brain and their body can catch up to each other and they can make good, healthy decisions for themselves and others around them. And then the relaxation technique, just, to get individuals to sit down, to take some deep breaths, to tense certain parts of their body. So they might want to start with their face and they want to grimace, and maybe that's fun and silly for them. Also, they can tense their hands, their arms, tense their legs. So they're going to tense and then relax and then develop some deep breathing techniques to help them get rid of some of the tension, help them reset their system so they can go back at whether it's at the day program or in their home setting and be able to function to their maximum benefit.
Awesome. Thank you, Teresa.
Yeah.
All right, sexuality and boundaries. Understanding sexuality. People with IDD have sexual desires and rights just as everyone else. Considerations for teaching about sexuality, education and understanding, potential risk, capacity to understand the concept of choice, biological age versus mental age, guardianship status of both parties, understand and be aware of your own personal beliefs, advocacy and self-advocacy, Carrie and Emma Buck, 1927, and Buck versus Bell, eugenics movement decade, 1920 to 1940, 3 generations of imbeciles are enough. At times, sexual behaviors can be a form of communication. Eugenics was a movement which originated in the 1920s that advocated to improve the genetic disposition of a population. During this time, people who were deemed to have what we would now consider to be IDD, often labeled feeble-minded or imbeciles in the past, would be sterilized. It was a practice that sought to improve the human race by reproducing only desirable traits. The most famous case was Buck versus Bell of 1927, where a 17-year-old Carrie Bell was deemed feeble-minded. Psychologists and doctors tested Carrie's mother, Emma, and decided there was definitely something wrong with her and that her traits should never be passed along. Emma claimed to not know who Carrie's father was. Carrie, who had an illegitimate child as well, is also deemed loose and feeble-minded by doctors. Although they could not report what exactly was wrong with her, the jury and Supreme Court agreed that they should both be sterilized for good of mankind. One juror, Oliver Wendell Holmes, famously said, 3 generations of imbeciles are enough. The people of this time truly believed that they were doing good by sterilizing people who were blind, mute, epileptic, or disabled in any other way. Understanding sexuality. Sexual behavior, stripping, an alternative may be sensory issues. So the client may be too hot or itchy. Exposing themselves, an alternative, a need to use a bathroom. Masturbation, understand time, place, and redirect. An alternate explanation could be boredom or frustration. Inappropriate touch, they may not understand boundaries. Request for hugs or kisses. An express need for physical contact. Behavior that appears to be sexual in nature may not always be. Boundaries. You will not be friends with your client, but you can be friendly. There's disinterested, neglectful, so under-involvement, Therapeutic relationship is the zone of helpfulness. Boundary violations, over involvement. A client who has IDD may need extra explanation or information repeated. For example, boundaries, especially about things such as why you cannot be friends with them on Facebook, or why you cannot hug them, or why you cannot socialize with them. You are not their boyfriend or girlfriend. We want to maintain a balance as professionals, not to be cold or unfriendly, but also do not cross a line and become friends with your clients. We are friendly people who help them and listen to them. Common boundary violations: self-disclosure of personal information, keeping secrets, using nicknames, terms of endearment, social media, receiving or giving gifts, borrowing, lending, buying, or selling, spatial boundaries, physically too close, physical contact, spirituality, and dual relationships. Some self-disclosure may be appropriate for some clients in some situations. Best practice is to check with your supervisor first before disclosing personal information about yourself to a client. Best practice is to ask before getting in someone's personal space and avoid physical contact, as it can be misinterpreted. Spirituality: your client may want to discuss their spiritual beliefs. However, it is usually not recommended to disclose your own. Facial expressions. Learning, teaching facial expressions. 7 universal emotions. Paul Ekman's classification of 6 facial expressions, which correspond to distinct universal emotions: anger, contempt, sadness, happy, fear, disgust, and surprise. Paul Ekman is an American psychologist and professor who is a pioneer in the study of emotion and their relation to facial expressions. The purpose of learning, teaching facial expressions. We as professionals need to develop our skills to recognize emotions in others. We need to be aware of what our own facial expressions are communicating to decrease misunderstandings. It may be necessary for us to teach facial expression recognition to our clients if they struggle with expressing, interpreting emotion. The next few slides are for your own information and may inspire you to teach your own clients. Right here is an example of anger. You will see that Laura has a tense brow, more closed eyes, tense lips, and a clenched jaw. She may also have clenched fist or hunched over if she's angry. Here I am displaying contempt. I am tightening one side of my face and tilting my head. This is a face of someone who thinks they are, that others may be beneath them or others are not worth their time. Here's Georgia displaying a pouty face. Her lower lip is thrusted out. She has a downhearted look in her eyes. She's clearly really sad about something. Here is Francisco, bright-eyed and bushy-tailed. He is super happy, showing lots of teeth, wide smile, bright eyes, relaxed brows. He is glowing. And then here is fearful, eyebrows pulled up, wide eyes, upper lip is lifted in fear, hands up, maybe shocked or maybe even to protect herself. Teresa is displaying disgust. Teresa's lip is curling into a frown. She's squinting her eyes, and then her brows are also frowned. And lastly, surprised. Here's surprised Allie. Eyebrows are raised, slight show of wrinkles on the forehead from wide eyes, open, relaxed mouth, and bright, happy eyes. And that concludes our presentation. Thank you for joining.